Recording. Hello, Professor. I'm John DeGarry. We're here with Jennifer, and we're going to be doing the week 6 assignment. Here we're going to be addressing health and healthcare disparities, and I'd just like to go ahead and get started. I'll be playing the role of the policymaker. She is the legislator, and we've come together on this assignment, and we're going to collaborate on some of ideas that we have to address healthcare disparities. First, I would like to address health and healthcare disparities and hopefully work towards a resolution on some of these issues. The main issue specifically is people having access to proper nutrition, and we're going to talk a little bit why that's important. The FDA reports that racial and ethnic minorities frequently experience health disparities, differences in health that are associated with genetic, social, economic, and environmental disadvantages. I believe our society should move towards a system that creates more equitable outcomes. So I'm going to talk a little bit about some of the examples of disparities in health that we specifically see in type 2 diabetes and obesity. Racial and ethnic minorities have a higher burden of diabetes, and poor diabetic control can lead to them experiencing complications. For example, among Hispanics, death rate for diabetes is 50% higher than for non-Hispanic whites. The American Heart Association reports African Americans are disproportionately affected by obesity. Among non-Hispanic Blacks aged 20 and older, 69% of men and 82% of women are overweight or obese. An example of disparity in food access is the existence of so-called food deserts. Healthypeople.gov describes food deserts as areas where food sources are lacking or limited, particularly in low-income areas. You will find that there are a higher share of convenience stores and small food markets. We can see how the lack of access to quality foods in poor neighborhoods are more likely to be populated with minorities, and this is going to continue the trend of minorities being diagnosed with obesity and type 2 diabetes. Another example of disparity is the affordability of quality food. Research shows that low-income groups tend to rely on foods that are cheap and convenient to access, but are unfortunately low in nutrient density. The lack of resources available to the poor minorities further perpetuates the health disparities that we see in society. And so coming together to collaborate and talk about some of the problems associated with this and what we can do. Jennifer?
Yes, hello. So in 2020, an estimated 1 in 8 Americans were food insecure. That equates to over 38 million Americans and 12 million children. To distinct between what hunger is versus food insecurity, we're going to describe hunger as a personal physical sensation of discomfort, while food insecurity refers to a lack of available financial resources for food at the household level. So things that many people take for granted, being able to open, the refrigerator and grab an apple or something healthy to eat, these Americans do not have that. So now we're going to talk about at a state level in the state of Hawaii. In the state of Hawaii, there are 162,220,000 that are food insecure, about 11.5%. So they measure that off a supplemental nutritional assistance program, and they go, it's 200, the threshold is 200% of the poverty level. So you're either above that or below that. Many things that contribute to these families and individuals becoming food insecure is a lack of public awareness that there are services that can help them. So if they are food insecure, they may not understand where they can go get healthier food to eat in the home and ways to help them. There could be a stigma attached to it. So they could be embarrassed with the fact that they need help for simple things like healthy foods. Transportation barriers, don't have access to get to the healthy foods. Housing insecurity. If you don't have a house, you may not be able to store foods. The lack of coordinated statewide plans for addressing food insecurities. So there's also a large body of research that directly coordinates and correlates, food insecurity with health and long-term health problems. Many diet-related diseases, as John said, diabetes, hypertension, heart disease, obesity, they kind of all play in together, and they are all can be associated with food insecurity. If you're a low socioeconomic status and you are, on a budget, the cheap pizza only costs $1.50 and the gourmet salad with a protein level of 30 grams costs well above that. So most people will go for what they can afford, which, as we all know, makes diabetes, hypertension, heart disease all increase. There's direct evidence that shows that adults with diabetes who are food insecure are more likely to have poor glucose control. Explanations for this may include engaging in cost-related medication underuse or non-adherence to prescriptions. For example, they could skip their doses, they're taking less medicine, or they're delaying the filling of their medications or refilling their prescriptions, postponing preventative or needed medical appointments and care, or foregoing the foods that they need for their diabetic care. So if they, take insulin, but now they need to eat, but they don't have the food to eat, they may not take the insulin, and the problem just keeps getting worse. Poor glucose control can lead to health complications in short and long term, as well as an increase of the use of our healthcare system. This is just one example and one small disease process that can, show the ripple effects of food insecurity that it can have on one person's health and the well-being and on the health system. So imagine if you take all of those people that I mentioned, the 162,220,000, and they all have one disease process that could be made worse by food insecurity. We have a huge problem on our hands. So John and I came together and we have a few strategies to help mitigate the problem. So John, I'll go ahead and say one, and if you want to come in and say the other. A possible solution is out here on the island, transportation could be a problem with getting these people the nutrient food that they require and need. So we could have a food distribution truck that could possibly distribute this. And it could also be, we have a lot of farms with produce. So if they want to donate food to this program, they could get a tax break in their business. And that way a lot of it wouldn't go to waste as well. John,
Yes,
you want to go ahead? Sorry.
yes, that's an integral part of our policy that we're proposing, is the additional routes and also expanding the food pantries. We have pantries in place in Hawaii now. We want to expand that program, have more food being available that is more healthy, promotes a more healthy lifestyle. In addition to the food that you'll find in the food pantry, we want to include educational pamphlets that'll educate patients on how to eat healthy and live a healthier lifestyle that hopefully reduce some of the risk factors we see with some of these diseases that are prevalent in the minority community. Drawing on the conclusions and some of the broader implications of health disparities, hopefully once this policy gets implemented, we can see some of those disparities not be so wide and narrow the gap on this. We want a more equitable system for everyone.
And then we could keep on going and pushing it out and push it up to federal level. If it works for one state, it could work for a lot.
Absolutely. I think this is a policy that shows a lot of promise. This concludes, I would say, our presentation.
Absolutely. Yep.
All right. Thank you, Professor.
Thank you.